But remember, I'm talking right now about my PCOS patients. I'm not talking about that, perimenopausal woman or someone out there who wants to lose 10 pounds, 5 pounds, patients who are already underweight and they want to lose 10 more pounds. And, they're not eating.
This is for PCOS.
This is for PCOS. I mean, 2014, I started using these medications.
Mm-hmm.
It's a game changer.
And how long would someone stay on it to conceive?
So
before?
It depends. So for someone who wants to lose 100 pounds, they might have to stay on it for 2.5 years. And the reality of it is, insulin resistance, metabolic health is not a one size fits all. Someone who loses 150 pounds with GLP-1s is probably never going to get off of these meds, But there are patients, my PCOS patients they lose 30 pounds, 40 pounds, 50 pounds on these GLP-1s. But what I do, I keep them on OV and metformin after they lose their weight. So if someone has insulin resistance, you give them GLP-1s and you stop it, what's going to happen? They shoot back up, right? Take a PCOS patient. Her insulin resistance is not going away. You give her GLP-1, you address her insulin sensitivity, you regulate her insulin, she loses 50 pounds, you stop it, the patient comes back 3 months later, she's like, doctor, I gained all of my weight back. Why? Because you did not address the underlying condition. So what I do with my patients, if you're starting on GLP-1s, in about 3-4 months when they get used to the GLP-1, that's when I introduce the metformin. And right when I start them on the GLP-1s, I have them take the OV supplement. So when I'm ready to stop the GLP-1s, they're already on the OV supplement, they're already on the metformin. I'm addressing their inflammation, I'm addressing their insulin resistance, I'm decreasing the load of carbohydrate that's being absorbed in their diet, and then I wean them off of the GLP-1.
Right.
You have to address the underlying disorder, if that makes sense.
Yeah. So what's the second pillar?
So the second pillar is the hormone pillar that I was explaining. When the insulin resistant stimulates your ovaries to secrete androgen, the androgen actually affects your GnRH secretion. It makes it very rapid, and this rapid secretion of GnRH causes a shift in the LH-FSH. So the FSH kind of stays down, and the LH chronically stays up. So instead of only going up mid-cycle causing ovulation, all month, this LH is firing. What does LH do? It stimulates your ovaries to release androgens. So then it becomes a vicious cycle. You have these androgens that block ovulation,